Your doctor checks the monitor, sees your blood pressure reading, and tells you everything looks perfect. But if you are over 70, that so-called perfect number might be the very reason you feel dizzy every morning, and growing evidence suggests it could actually be working against your longevity. Today we are going to talk about something most physicians will not bring up on their own. The blood pressure target you have been working toward your entire adult life may be completely wrong for your body at this stage. Most of us grew up believing that 120/80 was the gold standard, the number everyone should chase regardless of age. Your doctor says bring it down and you follow the plan without question. But here is what most people never learn. A large portion of the early research that shaped those guidelines was conducted primarily on middle-aged adults, people in their 40s and 50s, whose arteries were still flexible and responsive. The medical community took that number and applied it across the board to every age group, without fully accounting for how dramatically the body changes over time. And now even the latest medical guidelines are beginning to acknowledge that the approach needs to be more nuanced than a single target for everyone. In this video, I will walk you through what the research actually says about blood pressure for people over 65, including why your current medication could be doing more harm than good, and a simple test you can perform at home today that reveals what a standard office visit often misses. And at the very end, I will give you 3 specific questions to bring to your next doctor's appointment. 3 questions that could fundamentally change the way your blood pressure is managed from this point forward. Let us start with what happens inside your body after 60, because understanding this changes the entire conversation. As you age, your arteries gradually lose their natural flexibility. They become stiffer and less responsive. Think about the difference between a brand new garden hose and one that has been sitting outside in the weather for 15 years. The older hose does not bend the way it used to. It does not absorb pressure the same way. When your arteries stiffen, your heart has to generate more force to push blood through them. That naturally raises your baseline pressure. This is not a malfunction. This is your body adapting to a biological reality that every single person experiences with time. But there is a second change happening simultaneously that most people have never heard about. Built into your blood vessels are tiny pressure sensors called baroreceptors. Their job is to detect shifts in blood pressure and make instant adjustments. In a younger person, these sensors are remarkably fast. You stand up from a chair. They detect the change. They signal your blood vessels to tighten and your heart to pump a little harder, and blood continues flowing to your brain without interruption. You never feel a thing. After 70, those sensors become significantly less responsive. The adjustment that once took a heartbeat now takes noticeably longer. And if your resting blood pressure is already sitting at the low end because of medication, there simply is not enough pressure in reserve for your body to compensate properly. That is not a side effect of aging you should just accept. That is a physiological shift with real consequences that deserve attention. Have you ever felt lightheaded when you stood up too quickly? Have you reached for a wall or a door frame just to steady yourself? If that sounds familiar, stay with me, because what comes next may explain exactly why that keeps happening to you. And this is where things get truly important, because what researchers have been discovering about blood pressure targets for older adults challenges much of what we have been taught for decades. There is a significant and growing debate within the medical community about what the ideal blood pressure should be for people over 75. Multiple large-scale studies that tracked real older adults over extended periods, not theoretical projections based on younger populations, have found something that surprised many physicians. Pushing systolic pressure, that top number on your monitor, below 120 in this age group does not always produce better outcomes. In fact, some of these studies observed that older adults whose pressure sat moderately higher experienced fewer hospitalizations, maintained sharper cognitive function, and had lower overall mortality rates compared to those who were aggressively medicated to hit the traditional target. Several international guidelines, including those from Japan and parts of Europe, have already responded to this evidence by recommending more relaxed targets for people over 75, aiming for below 140 rather than below 120. Now, I want to be very clear about something. None of this means that high blood pressure is suddenly harmless. Uncontrolled readings consistently above 160 or 170 remain dangerous at any age and absolutely need treatment. What the research is telling us is that there exists a zone that is too low for an aging body to function safely, and millions of people over 70 are being medicated right into that zone without anyone recognizing the problem. This might mean that the number your doctor calls excellent may not actually be excellent for your particular body at your particular age. You deserve to know what number truly fits your situation. Do you know your current systolic blood pressure reading? Type that number in the comments below, or type "not sure" if you are uncertain. It helps me understand where our community stands on this. But here is the part that genuinely concerns me, because when blood pressure medication pushes your numbers too low, the consequences can be far more severe than most people realize. Research has consistently demonstrated a meaningful connection between antihypertensive medications and an increased risk of serious falls and fractures among older adults. And when we talk about a serious fall at age 75 or 80, we are not talking about a minor bruise or a scraped knee. We are talking about a shattered hip, a traumatic brain injury, weeks or months in a hospital bed. For many older adults, a fall like that marks the beginning of a steep and rapid decline in independence, mobility, and overall quality of life. Here is the painful irony that keeps me up at night. Doctors prescribe blood pressure medication to protect the heart and prevent strokes. That is a completely worthy goal. But when the medication drives pressure too far down, it creates the conditions for a fall. And a fall at that age can produce exactly the kind of devastating trauma, a brain bleed, a cardiac event, from the shock that the medication was originally prescribed to prevent. The very treatment designed to shield you ends up generating the precise danger it was meant to eliminate. And what makes this especially difficult to catch is that the fall never happens in the doctor's office. It happens in your home. At 6 in the morning, when you swing your legs out of bed and stand up to walk to the bathroom, your blood pressure drops before your sluggish baroreceptors have time to respond. You stumble. You grab for something. Maybe you catch yourself. Maybe you do not. And when it shows up in a medical chart, it is recorded as a mechanical fall. Patient lost balance. It was not a balance problem. It was a pressure problem. And it was entirely preventable. If you or someone you love has experienced an unexplained fall, this could be the missing explanation. And more importantly, this is something that can be addressed before it happens again. But falling is only the visible part of this problem. What is happening inside your brain when blood pressure runs chronically low is arguably even more alarming. Your brain is the single most resource-hungry organ in your entire body. It accounts for roughly 2% of your total body weight, yet it demands close to 20% of your oxygen and blood supply every single minute without pause. The moment that supply drops even slightly, your brain begins sending distress signals. In a younger person with responsive baroreceptors and flexible arteries, a momentary dip in pressure gets corrected almost instantly. The system adjusts within a beat or two, and you never notice anything happened. But in a body over 70, where arteries are stiffer and those pressure sensors respond more slowly, and where resting blood pressure is already being held artificially low by medication, there is almost no buffer remaining. You stand up. Gravity pulls blood toward your legs. Your pressure drops. And instead of recovering in a second or two, the correction takes several seconds longer. During that window, your brain receives less blood than it requires. Most people do not faint. What happens instead is subtler. A brief wave of dizziness, a slight darkening at the edges of your vision, a momentary feeling of unreality that passes quickly and that you have probably trained yourself to ignore over the years. But here is what most people are never told. That process repeated every morning, every time you rise from a chair dozens of times throughout each day is not harmless. A growing body of research now links chronic low-grade underperfusion of the brain to accelerated cognitive decline in older adults. Your brain is consistently receiving slightly less blood than it needs to function optimally. And over months and years, that quiet deficit accumulates into something far more serious than occasional dizziness. So let me ask you something honestly. Do you feel lightheaded or unsteady when you get out of bed or stand up from a chair? Do you wake up feeling unusually exhausted even after a full night of rest? Has your thinking become noticeably slower? Words, taking a moment longer to surface, losing your train of thought in the middle of a sentence. Do your legs sometimes feel weak for no apparent reason? Have you had moments where it felt like you might pass out, even though you did not? If two or more of those sound familiar, those may not be signs that you are simply getting older. Those may be signs that your medication dose is too high for your body right now. The medical term for this is iatrogenic hypotension, which is a technical way of saying the treatment itself created the problem. These symptoms are routinely dismissed. Patients mention dizziness and hear that it is just part of aging. Fatigue gets attributed to poor sleep. Slower thinking gets labeled as early cognitive decline. And sometimes those explanations are accurate. But more often than the medical system readily admits, the real culprit is simply a medication dose that is too aggressive for that specific person at that specific age. You deserve to know the difference. If you are still watching and finding this information valuable, type "still here" in the comments below. It lets me know this content matters to you, and every comment motivates us to keep creating evidence-based health content. And now we reach the part where you can actually take action today, because there is a simple test that every person over 60 should know about. It takes about 5 minutes, costs nothing, and can reveal more about your real cardiovascular risk than a routine office visit. It is called the orthostatic blood pressure test, and here is exactly how to do it. First, you will need a home blood pressure monitor. If you do not already own one, consider it a priority. For anyone over 60, this is not an optional gadget. It is a fundamental health tool as essential as a thermometer. Step 1. Lie down flat on your bed or couch. Rest quietly for a full 5 minutes. Do not talk. Do not scroll through your phone. Just let your body settle. Step 2. While still lying down, take your blood pressure and write down both numbers. Step 3. Stand up the way you normally would in the morning and immediately take your blood pressure again within 60 seconds of standing. Write down both numbers. Step 4. Compare the two readings. Here is what you are looking for. If your systolic pressure, the top number, drops by more than 20 points from lying to standing, that is called orthostatic hypotension, and it is a red flag. A drop of 20 points or more means your body is not compensating quickly enough for the change in position. That gap between your lying pressure and your standing pressure represents the window during which you are vulnerable, unsteady, dizzy, and one unexpected misstep away from a serious fall. If you discover this drop, do not simply dismiss it as normal. Write those numbers down and bring that piece of paper to your next appointment. There is one more critical reason to monitor your blood pressure at home regularly. The latest medical guidelines emphasize that readings taken in a clinic do not always tell the full story. Many people experience what is known as white coat hypertension, where blood pressure spikes in the doctor's office due to the stress of the visit, but remains perfectly normal at home. The reverse also happens. Some people have what is called masked hypertension, where readings appear fine in the clinic, but are actually elevated at home during daily life. Both situations lead to incorrect treatment decisions, either too much medication or not enough. Regular home monitoring gives you and your doctor the most accurate picture of what is truly happening with your blood pressure day to day. That kind of data puts you in the driver's seat of your own health. This test and these home readings hand you the power. Instead of waiting for your next appointment and hoping for the best, you can identify a potential problem today in your own home on your own terms. Now that you have the data, the natural question becomes, what numbers should you actually be aiming for? And this is where things get more complex than most people expect. The 2025 guidelines from the American Heart Association and American College of Cardiology, the most comprehensive and current available, reaffirm a general target of below 130/80 for all adults, with encouragement to reach below 120/80 where possible. At the same time, and this is critically important, these same guidelines now explicitly recommend that when patients are being treated aggressively, clinicians should actively assess for symptomatic orthostatic hypotension to catch hidden problems before they become dangerous. That is a significant acknowledgement. Meanwhile, other respected international guidelines take a different position. Medical authorities in Japan and across parts of Europe recommend more flexible targets for very elderly patients, suggesting below 140 for those over 75 and below 150 for those over 80 or individuals with significant frailty. The essential point is this: there is no single magic number that works for everyone. Your personal blood pressure target must account for your age, your kidney function, whether you have diabetes, any history of stroke, which medications you are currently taking, and your overall level of physical resilience. Many physicians still apply older, more aggressive targets, not because they are careless, but because medicine evolves continuously, and the evidence surrounding blood pressure management in older adults has shifted substantially over the past decade. This is not about blaming your doctor. This is about updating the conversation together. What this means for you is straightforward. You have both the right and the responsibility to ask your doctor what specific number is appropriate for your individual situation and what evidence supports that target. And that leads us to the most important part of everything we have covered today. Most people walk out of a doctor's appointment having expressed maybe 30% of what they actually wanted to say. They feel rushed. They do not want to come across as difficult. They assume the physician knows best and leave the rest unsaid. I want to change that for you right now by giving you 3 specific questions to bring to your very next visit. Write these down or save this video so you can reference them later. Question 1. Given my age and health history, what is my individualized blood pressure target, and what is the evidence behind that specific number? Do not ask whether your pressure is okay. Ask for the precise target and the precise reasoning. A thoughtful physician will welcome that question because it shows you are engaged in your own care. Question 2. Can we check for orthostatic hypotension during this visit by measuring my blood pressure both lying down and standing up? This test takes approximately 3 minutes in a clinical setting. Many doctors do not perform it as part of their standard routine, but when a patient requests it directly, most will carry it out without hesitation. You now understand why this measurement matters, and you can explain that to your doctor if needed. Question 3. Could any of my current symptoms, the dizziness, the fatigue, the mental fogginess, the leg weakness, be related to my blood pressure medication dose rather than to aging itself? This single question opens a door that often remains shut. It gives your physician explicit permission to consider over-medication as a real possibility instead of automatically attributing your symptoms to age or unrelated conditions. That shift in thinking can change everything. You are not being difficult by asking these questions. You are being an informed, engaged patient. And informed patients consistently receive better care. The best possible outcome for your health comes from a genuine partnership between you and your physician, not from passively accepting whatever number appears on a prescription label. What you have been feeling may not be inevitable. It may not simply be aging. It may be entirely fixable through a conversation, a test, and a medication adjustment that takes 15 minutes to discuss and could reshape the next 10 years of your life. That is not a small thing. That is everything. As we have explored today, blood pressure management is not a one-size-fits-all equation, especially after 65. Understanding how your body changes with age and knowing how to test yourself at home are the first steps toward truly taking charge of your own health. Now it is your turn. Of the 3 questions for your doctor, which one will you ask first? Drop your answer in the comments below. If this information could help someone you care about, please share this video with them. Hit the like button so others can discover this important content, and subscribe with notifications turned on so you never miss our evidence-based health updates. I believe that the best health outcomes after 65 come from a smart partnership between you and your doctor, and that partnership starts with the conversation you choose to have today. We have prepared more videos on cardiovascular health for adults over 50. Check the description below to watch. As always, please discuss any changes with your own physician before taking action. Thank you for watching, and here is to your health.